I just need to record. All right, welcome, SLP212. Okay. Module 14, autism disorder. So hopefully this is not your first experience with autism. And even if you haven't really learned about it in another class, I hope you are at least heard about it, have some idea about it. It will be one of the most prevalent disorders that you treat as an SLPA or an SLP. Again, no two people with autism are alike. And the definition now is so broad. I mean, we're really looking at a wide variety of skills. So a lot of times when we talk about autism, we talk about things in generalities. So please know, you might have a client with autism that doesn't necessarily fit any of the molds we talk about. So you're having difficulty, you have a client, they have a diagnosis of autism, and you're not, things that, they're not kind of fitting what you have in your mind that they have difficulty with. Please talk to your supervisor about it. I have to say, Arizona is not really good about differential diagnosis. I don't know, the rest of the country, I don't know, is better or worse. But a lot of times we see comorbid. So somebody with fetal alcohol syndrome might also have a diagnosis of autism. Somebody with Down syndrome might also have a diagnosis of autism. So a lot of times it's another disorder, or they fit some profiles of autism, but also other disorders also kind of fit some of the features. So really, number one thing, common features of autism: difficulties understanding, using verbal and nonverbal communication. So gestures, facial expressions, body language, poor social awareness and interactions with others. So a client that has difficulty interacting with others, and you can have that difficulty with a variety of issues. So a lot of times these features show up with other disorders too. So limited or absent imaginative play skills. So again, when we're talking about play therapy, and hopefully you're not having to justify to somebody why you're doing play-based therapy with a client, but this is part of why we work on it. Definitely somebody who has a diagnosis of autism or at risk for autism, we want to see that imaginative play skill. It's a critical skill for a variety of cognitive functions, and then less able to interact with the world as other children. So definitely we see some of our clients who challenge with sensory things, maybe keep to themselves, not really interact and seek their environment. So here's those are common features and common difficulties, but not always experienced with a person with autism. So poor understandings of the conventions of social interactions, deficits in developing and maintaining relationships, limited play interests. So definitely if we see somebody, we have a client that only has like one or two things they're willing to do or play with, that's kind of a red flag. So definitely variety. So a lot of times too, I don't know how many times when I was an SLPA as well as an SLP, the parents like, well, you're just playing with my kid. Yeah, but we're working on skills and I'm trying to expose them to other things. Or I've had a parent, say, especially in a clinic where they're there, well, my child doesn't like that. He won't like that, or she doesn't want to do that. Okay, but we've got to try to push our clients to experience new and different things. So definitely a variety of play items is important. They might experience difficulties in sharing and use of imaginative play, deficits in social emotional reciprocity. So this is where we're seeing that back and forth in response to the situation. Definitely some things too that when we're looking at that reciprocity. So a lot of times we'll see a client with autism who's perfectly happy all the time and not really responding, having appropriate social emotional responses to the situation. Stereotyped or repetitive speech, motor movements, or use of objects. So a repetitive use of object, a lot of times not the function of the object, and then echolalia. So hopefully you've heard that word in another class, but echolalia truly is where they just repeat what you say. And they don't have necessarily any spontaneous responses. So we will see echolalia in a variety of language and speech impaired clients, but the echolalia, when we're referring to clients with autism, it's definitely where they don't have spontaneous use of speech. A lot of times kids repeat what you say to kind of process it, but really we're looking for those organic, spontaneous responses. Excessive adherence to routines and rules, so very rigid. Hyper or hypo, so they could be too much or not enough reactivity to sensory input. So, or an unusual interest in the sensory aspects of the environment. So sometimes they're interested in things in a non-typical manner. So that might look like having a weird obsession with the carpet or the floor or a light, a fan, something like that. Resistance to change, resistance to change, and then also they don't initiate. So they're not one to go up and initiate with another person. They kind of wait for people to come to them. Can be impulsive or aggressive. Again, that could be a lot of other disorders too. Poor nonverbal communication, and then limited understanding and use of language or poor understandings of instructions, questions, or jokes. So definitely when we're working on goals for yes, no questions, WH questions, we're working on that receptive language component for a variety of disorders, but really it is important to address when we're working with clients with autism. So management strategies, so you can kind of look at that. I'm not going to go over all of those things, but what I want to say is occupational therapy approaches and activities that can support a child with autism. Now, I want to say this is labeled OT, but a lot of this is stuff that speech pathologists, speech assistants, ABA therapists, as well as occupational therapists might use. So these are just strategies to use. It's not like a discipline owns them. Now, I do want to say just my little tidbit on sensory. I feel as speech therapists, we throw that word around a lot in some other disciplines, but truly, if you want to call something sensory, you should be talking to the occupational therapy person that is in the team. So whether that's clinic-based, home-based, school-based, because a lot of times we excuse things as sensory and they're maybe not. So really don't be one to throw that or call a behavior sensory without knowing if it's sensory or not. So just FYI, like I really don't want to hear from a colleague. So I have a therapist I work with time to time who loves to say all these behaviors are sensory. And then when you talk to the OT, the OT's like, well, first of all, this child doesn't register anywhere on the sensory processing measure. They've had no OT. This is just behavior-based stuff. This isn't sensory-based behavior. So just FYI, using social stories. So a variety of people use social stories. Speech therapists, OTs, ABA, teachers are helpful for a variety of reasons and helps give them some predictability about what will happen, how should we respond in a situation, like particular to a certain activity. For instance, I made a social story about getting on the bus and getting off the bus, just because that was a difficult transition for a client I've worked with, or getting up and getting dressed, or going to bed. So all of these things help, and you can write a social story for any numerous things. So anything they're having difficulty with transition, social stories can be helpful, not always. Sometimes though, so this is what I found. It's funny, I was talking to another therapist about this. So social stories are helpful. The problem is that sometimes then we train them, or I don't want to say train them, but they kind of get, if things don't happen exactly the way the social story is written, then it's like we kind of reinforce that rigidity. So there are certain clients, if I've used a social story and I've seen that, I don't like using them again. I do some different varieties of social, I call it social predictive, versus a story where this, and this will happen. So I do find sometimes with some clients with autism that social stories become more restrictive for them, not necessarily as helpful as they maybe once were. So visuals. So the other part too is if they're auditory comprehension, a lot of times they're not, especially if they're nonverbal, they're not necessarily auditory learners. So those visual cues are really important. Variety of people use those. Setting up a routine. So a predictable routine is helpful. And physical skills. So definitely looking at what physical skills might the client need to interact with others. And really, truly, all of these kind of strategies support a lot of other disorders too. And then expanding those abilities. So obviously too, when we use a strategy to develop a skill, we also want to see that skill occur in other areas. So that generalization piece is super important. So obviously for us, what we're focused on usually, our main focus is communication strategies and developing language, hopefully developing some type of conversation skill if they have obtained some kind of communication, whether that's picture-based or verbal, and then working on emotions, empathy, social skills. So truly, when I think about communication, sometimes I have to define for a family, I'm talking about not always talking. So a lot of times people they coincide communication with talking, whereas us as therapists, we're just looking, are they able to convey a message meaningfully? And again, sometimes we have some differences of opinion. So when you're struggling with communication strategies with a particular client, especially with a client with autism, definitely consult with your supervisor. Hey, this is working. Or what you find too is you start using some type of visual system and then they start to become verbal, because that's what the research supports. Or you see sometimes families really against using some types of visual or picture exchange, some type of symbol-based communication. So definitely looking at the teaching alternative forms of communication if verbal is not coming. And I want to say too, always as a therapist, we're always supporting verbal communication whenever we can. But the important part is, can they convey their message, easily and effectively to get their needs and wants met? And then obviously too, you guys as SLPAs aren't diagnosing autism. Even us as speech therapists, we're not diagnosing autism. That goes down a different avenue. But we definitely should refer. So sometimes you'll get a client, they've got, global speech and language delays. And then as you start working with them, you start seeing some of these characteristics. And, your supervisor hasn't mentioned autism, hasn't mentioned at risk of autism. Please speak up and talk to your supervisor right away. Let her know what you're seeing, or he or she is seeing. And so they can kind of work on getting the other appropriate interventions. So what we always hope too, a lot of times, I'll have to say this about our clients with autism. A lot of times speech therapy is the first stop. They don't go down the road. They go, oh, let's do some speech and language therapy. Let's get them talking. They're just language delayed. So sometimes we're the first step. And a lot of times your supervisor might need to be pushing the family to seek other services, get extra help, and might need some of this evidence. So as you're working with a client and you see these things, you have to kind of make sure you're communicating with your supervisor about your concerns, as well as what you're seeing, so your supervisor can then kind of get the next steps going or support the family in getting those going. All right. So the good part, you guys, is even as us as speech therapists, we're not diagnosing autism, but we see the signs. Every time we hear that song, I saw the signs. I'm always think that from a diagnostic perspective in speech. I'm like, oh yes, we see the signs for sure. There's some good resources. There's a lot on the internet. I don't even have to tell you about that, I'm sure. But I do like some of this. I know some of these autism groups can be controversial, but I do, when I look at this, I like how, they kind of discussed about it, list of signs and symptoms, and sometimes too, you bring it up. So Asperger's syndrome. So what I want to say is that is no longer a separate diagnosis. So it still is used, and it's a rare, or it's a newer concept. So 2013 was when they kind of took that diagnosis out of the DSM. So the Diagnostic and Statistical Manual of Mental Disorders. So they took Asperger's out. So before it was kind of considered, a high functioning autism, a separate disorder from autism, but definitely what we've looked at is they've just increased the umbrella. So we used to have autistic disorder, pervasive developmental disorder, and then Asperger's. So since I'm starting to become a dinosaur here, what year am I in? My 23rd year, 24th year. To me, I see a lot of pervasive developmental disorder, or that's what I would call it, versus autism or Asperger's. I still sometimes try to catch myself and not use that, but I think a lot of times too, and I'm trying to work on this because it's not, want to maintain the integrity of the diagnosis, is I'll say high functioning autism. So there is a spectrum. We've got clients who are very, what we would consider low functioning, impaired in a variety of ways, have limited language, limited, communication. And then we have high functioning where they have language, they have ability to communicate, just maybe have some social problems. So I try to remember, you'll see it, sometimes you'll still see it written. A person, especially I work with a lot of adolescents, they identify as somebody with Asperger's rather than autism. And the other part too, I think the biggest difference between the two were, a lot of people with, autistic disorder had cognitive impairment, whereas Asperger's, they don't have cognitive impairment in the traditional sense. They have some other impairments, but they don't have that intellectual disability component. So definitely look at that. So I liked this website because it kind of went through some of the characteristics and the differences, because that usually comes up. And like I said, it's a newer thing, only 7 years. It takes a while for us to get, on board with how, all the new DSM terminology. So when you go through here to the practice portal, you can go through some of these disorders. So if you're ever looking, so I do like this website or this page on the ASHA website. So on autism spectrum disorder, you will find a plethora of information. You can look at how ASHA kind of defines it. And kind of gives you more of the history. So definitely, and then they added a new thing, so that social communication disorder, I haven't really added it to this a whole lot, but you can read about that. They've kind of how do they differentiate between the two. So that's what's kind of nice on this practice portal, talking about some of those differences. And the nice thing, your supervisor a lot of times just kind of reverts to what the psychologist said. So usually the psychologist is teasing all this out. And then we give our input on their speech and language abilities. And obviously we're treating them. So you guys as SLPAs are treating them because they have a deficit in an area. They struggle usually with some type of language, some type of expressive language, some type of social piece. So definitely for us, it doesn't really matter what the primary diagnosis is. Here are the things that we're treating, regardless of what we call it. So just know we always treat the symptoms, not the disorder. So a lot of times it's not really relevant. No, I shouldn't say that. A lot of times it doesn't matter if it's autism or something else. They have impairment with social communication, we're going to treat the social communication. They have impairment with reciprocal language, we're going to work on that. Comprehension, we're going to work on that. So we try not to get too hung up in the primary diagnosis. So there's an, let me look at the vocab. Oh, perseveration. So I just want you to be aware because you will see it, that Asperger's, where that came from, and then pervasive developmental disorder, that was another part of the autism umbrella. And now it's just autism spectrum disorder. So be familiar with pervasive developmental disorder, that old category, and what was involved in that, as well as perseveration. So we talked about echolalia. So perseveration occurs in a variety of disorders also. But just be clear when we're talking about perseveration, how does it relate to autism? For me, when I have an SLPA, so for instance, my SLPA, Corey, if she used perseveration, I want to make sure her and I are on the same planet with what perseveration is. So just kind of know, be familiar with that. And then maybe sometimes you have to define some of this with your supervisor as you're working. Like I said, perseveration is one of those more broad words. So it can kind of get to where you want to be sure you and your supervisor are on the same page. Because as you know, in speech, we have a million names for the same thing. So and everyone's, it's kind of like the telephone, everyone's got a little bit different version of it. So there's an autism therapy observation. So check out Lulu. And we have another one, Beth. So they're like two different ages. So I like kind of looking at the difference there. And then, so this is what the compare and contrast. So you watch two different ones. So really what I'm looking at is, did you notice some of the differences, or did you notice some things that are similar? And, be sure that you're giving evidence-based examples of what you watched in the session. Now, this is where you guys, I'm not expecting you guys to be SLPs and diagnose or any of that. Just what was your interpretation of what went on in the session? What was the therapist doing? How did the client respond? From the young client to the older client, both with the same diagnosis. So I really want you to kind of see the differences there. For instance, I have a particular student I've worked with. He's 13, 14 now. I had him as not even a 3-year-old. And to look at where he was then to where he is now, it's like not even the same child. And, he came in nonverbal, unresponsive to his environment, not even able to, engage with anybody. He's in gen ed all day. He can do gen ed work. He really doesn't, he still got some social stuff. But what he looks like now looks a whole lot different than then, and how much, you know, but there's still some of the same things that he still struggles with, just at a different level. Things that he struggled with at 4 and 5, he can still struggle now at 13 and 14, just in different ways. So a lot of times it's the same skill, it's just a different level of the skill. So hopefully you can pick out some of those. I'm not looking for you guys to critique the therapist, or just what was your impression? What did you see them try to address in each one? How is it same, different? So just, I think some people stress about that. If you were an SLP in training, you know, how to diagnose some of these things I'd be a little more critical. Did you notice differences? All right. So the compare and contrast therapy session is on the 2 observations that you did. So I'm not asking you to watch 2 other ones. I'm asking you to look at, you know, 1 and 2, and then compare and contrast those. And then there's a read and review summary. So there's no assessment this week. It's more about kind of the reflection of what you watched. And it's really hard, you guys, for autism is different with each client. Like I said, we talk in generalities, but hopefully you're familiar with it. We've talked about the prevalence. It's very prevalent, and it's occurring a lot. You will experience it, you will see it, you will treat it on a regular, if not daily basis, as you guys become SLPAs. So just wanted to get a lot more comfortable with the verbiage, the terminology, and, you know, as well as you should be talking to your supervisor about all of your clients, but really our clients with autism can be challenging for a variety of reasons, and you and your supervisor definitely need to be on the same page. So any other questions? If not, I want you guys to enjoy your week. Hopefully everybody's staying safe, you know, not too many people. As I'm coughing, and it's so dry. I mean, I've been itchy. I just took an allergy pill too. I know I was coughing. I told my husband, oh my gosh, I don't want to be around anybody when I cough, but everyone's looking at you like, oh, do you have the virus? So yes, be safe. If anybody is needing more time, please contact me right away. Obviously this week can be busy for a variety of reasons. So if you do need more time, that's fine. Just let me know ahead of time. So, alrighty, you guys have a good night. I appreciate your time in joining me.